high-energy musical sting.
Welcome back to Crash Cart Questions. Let's jump right into our first case.
So, you're in the ED with a 68-year-old who has a clear inferior STEMI. You're getting things moving for the cath lab, and then everything falls apart. He suddenly deteriorates. He's hypoxic. His pressure has absolutely cratered to 78/55. And when you put your stethoscope on his chest, you hear a brand new, loud, pansystolic murmur right at the apex. Your alarm bells should be screaming.
So, what's happened here? What's the mechanical catastrophe that just blew up your stable STEMI patient?
This is a papillary muscle rupture. That inferior MI has completely knocked out the blood supply to the muscle, it's torn, and now you have acute, severe mitral regurgitation. That valve is just flapping in the breeze. Blood is pouring backwards into the lungs, and that's what's causing this profound cardiogenic shock. Okay, you've made the likely diagnosis, but this guy is dying in front of you. What are your immediate, life-saving priorities right now?
First things first, resuscitation. You've got to support his breathing, and that could mean CPAP, or more likely, rapid sequence intubation. Next, that blood pressure. He needs inotropes, like norepinephrine, to bring it up. You also need to reduce the afterload to help the heart pump forward. So you could consider nitrates, but you've got to be incredibly cautious with that BP. And at the same time, you need that ultrasound probe on his chest, STAT, to confirm what you're seeing, while getting cardiology and cardiac surgery on the phone immediately.
So you've stabilized him for the moment, but how do you actually fix this? What's the definitive treatment? This is a surgical emergency, plain and simple. There's no medical fix for a torn muscle. This patient has to get to the operating room for an urgent valve repair or a full-on replacement. All right, let's switch gears to our next case, a true toxicology classic. Okay, here we have a 28-year-old woman who's taken an overdose of amitriptyline. She's drowsy, her heart is racing at 135, her pressure's pretty soft at 95/60, and you notice her mouth and mucous membranes are bone dry. You're already seeing a pattern here. But this is the finding that should make your stomach drop. You get the ECG and you see a QRS duration of 140 milliseconds. That is wide. This is the classic signature of sodium channel blockade, and it's your biggest warning sign for impending seizures and deadly arrhythmias. So let's put it all together. The drowsiness, the tachycardia, the dry membranes, the whole clinical picture. What toxidrome are we looking at? This is a textbook anticholinergic toxidrome, all thanks to that tricyclic antidepressant. You know the old saying, mad as a hatter, blind as a bat, red as a beet, hot as a hare, and dry as a bone. It fits perfectly. Now, knowing this and seeing that wide QRS, what are the immediate life threats that you need to get ahead of? What are you trying to prevent? The big killers are cardiac. We're talking about ventricular tachycardia and VFib, driven by that sodium channel blockade. You also have to be ready for severe hypotension that doesn't respond to fluids, seizures, and a deepening coma that's going to require you to protect her airway. Okay, so you know the dangers. Lay out your specific management plan. What are you going to do to treat this overdose? Job one is always resuscitation. ABCs. Get your IVs, get her on a continuous cardiac monitor. If she starts to seize, the answer is benzodiazepines. And now for the critical antidote, IV sodium bicarbonate. You give a bolus and then start an infusion. The goal is to narrow that QRS and stabilize the cardiac membrane. If she's still hypotensive, you'll need to go to inotropes. And of course, this is a patient who needs an ICU bed, so get them involved early on. All right, enough with the long cases. Time to pick up the pace with an MCQ lightning round. First up, in a child, what is the absolute narrowest part of the airway? Is it A, the vocal cords, B, the cricoid ring, C, the oropharynx, D, the epiglottis, or E, the subglottic trachea? And the answer is B, the cricoid ring. This is a classic, high-yield pediatric anatomy. It's a huge difference from adults, and it's why we traditionally used uncuffed tubes in small kids. Question 2. You have a patient with penetrating neck trauma. Which of these is considered a hard sign demanding immediate action? Is it A, subcutaneous emphysema, B, dysphonia, C, an expanding hematoma, D, a small amount of hemoptysis, or E, a non-pulsatile bruit? The answer here is C, an expanding hematoma. That sign means there's active, uncontrolled bleeding, and it's a non-negotiable ticket to the operating room. All the others are considered soft signs, which still need investigation, but don't have that same level of urgency.
And that distinction is absolutely crucial. Fantastic job on this round. To keep your skills sharp for that next critical patient, make sure you subscribe for more crash cart questions. We'll see you for the next one.